Good morning, everyone, and welcome back to the cardiovascular system too. In this lecture, we will be discussing the ischemic heart diseases. Ischemic heart disease is a broad term, including several closely related syndromes caused by myocardial ischemia and inadequate oxygen supply. This usually happens due to an imbalance between the cardiac blood supply in one hand and the myocardial oxygen and nutritional demands on the other hand. Why it's important? Because ischemic heart disease is the leading cause of mortality in the United States and other developed nations, accounting for 7 million deaths worldwide each year. Ischemic heart disease happens usually when the myocardial perfusion or blood supply cannot meet the demands. This can happen due to one or several pathologies affecting the myocardial perfusion and or the demand. The first, when the coronary lumen is narrowed by atherosclerotic plaque, which we call usually the coronary artery disease. This will result in decreased myocardial perfusion, so the oxygen and nutritional supply cannot meet the demands. This accounts for more than 90% of ischemic heart disease cases. Another mechanism, when the demands are increased, as in patients with increased heart rate or hypertension. In some cases, the blood supply is okay and the demand is not increased, but the blood volume is decreased, as in patients with hypotension or shock. Another mechanism, when the blood supply is okay, the demand is not increased, and the blood volume is normal, however, the oxygenation is decreased. This may happen in patients with pneumonia or congestive heart failure. Another scenario, when the oxygen carrying capacity is decreased, and this may happen due to anemia or carbon monoxide poisoning. Ischemic heart disease can present as angina, acute myocardial infarction, chronic ischemic heart disease with congestive heart failure, sudden cardiac death. The first clinical syndrome of ischemic heart disease is angina pectoris. Angina means literally chest pain. So here there is an ischemic event, and the ischemia is sufficient to induce pain. However, it's not sufficient to cause myocyte death, so there is no myocyte death. Angina pectoris can be classified into stable angina. This type of angina happens after certain level of exertion and does not happen at rest. Prinzmetal angina. This type is caused by vasospasm. Unstable angina. In this type, the chest pain starts to happen with less exertion or even at rest. The second clinical syndrome of ischemic heart disease is acute myocardial infarction. And here the severity or the duration, or both, the severity and the duration of ischemia is sufficient to cause myocyte death. So there is a real myocyte death. The third clinical syndrome of ischemic heart disease is the chronic ischemic heart disease with congestive heart failure. This usually happens due to progressive cardiac decompensation after an acute myocardial infarction or secondary to multiple small ischemic insults that will eventually participate in mechanical pump failure. Then the fourth clinical syndrome of ischemic heart disease, which is the sudden cardiac death. It may happen as a consequence of tissue damage from myocardial infarction, but most commonly results from the lethal arrhythmia without myocyte necrosis. Then we come to the term acute coronary syndrome. Acute coronary syndrome, this term is applied to any of those three catastrophic manifestations of ischemic heart disease. The first is the unstable angina, the second is acute myocardial infarction, and the third is the sudden cardiac death. So only unstable angina, acute myocardial infarction, and sudden cardiac death are called acute coronary syndrome. As I said at the beginning of this lecture, ischemic heart disease is a consequence of inadequate coronary perfusion or blood supply or oxygen and nutritional supply in relation or in comparison with the myocardial demands. The most common cause is the presence of a fixed, pre-existing or permanent atherosclerotic occlusion of the coronary artery. So the coronary artery is occluded by certain percent of the lumen permanently by the presence of the atherosclerotic plaque, and also the presence of a new superimposed thrombosis and or vasospasm resulting in more narrowing of the vascular lumen. وهون بيجي سؤال مهم، وهو كم نسبة الانسداد in the coronary artery lumen اللي بعدها ببلش مريض الاسكيميك heart disease يحس بالأعراض. This is what we call critical stenosis. نسبة الانسداد التي يبدأ بعدها المريض بالإحساس بالأعراض هي أكثر من 70% of the coronary artery lumen. So the critical stenosis is when the lesion occludes more than 70% of the vascular lumen. شو بيصير عند المريض؟ This will cause symptoms with increased demands. إذا ببلش المريض يحس بالأعراض. معنى ذلك إنه أي ليجن عامل fixed obstruction أقل من 70% المريض رح يكون asymptomatic حتى لو عم بيلعب رياضة أو حتى لو كان هذا المريض عم بيطلع درج. So the fixed obstructions that occlude less than 70% of the coronary vessel lumen typically are asymptomatic even with exertion. طيب متى بصير عند المريض stable angina ومتى بصير عند المريض unstable angina؟ Stable angina, which is the chest pain that happens after certain level of exertion, happens usually when there is an occlusion of more than 70% of the vessel lumen at certain level of exertion. Unstable angina, which is defined as the chest pain that happens with minimal exertion or at rest, this happens usually when there is a fixed stenosis occluding more than or equal 90% of the vascular lumen. As you can appreciate in this figure, this is a patent coronary artery. There is no fixed occlusion, and as you can see the layers from the innermost layer, it's the intima, then the middle layer, which is the media, and then the outermost layer, which is the adventitia. In this figure, the coronary artery is involved by an occluding plaque of less than 70% of the vascular lumen, so the patient is asymptomatic. Here, the coronary artery lumen is involved by an atherosclerotic plaque occupying more than 70% of the vascular lumen. This can result in chest pain after certain level of exertion, which we call stable angina. Atherosclerotic plaques, as I said in the previous lecture, are prone to ulceration, erosion, and maybe rupture. So sometimes due to the turbulent flow over the atherosclerotic plaque, the surface becomes eroded, and this will expose the highly thrombogenic subendothelial tissue, resulting in thrombus formation and platelets aggregation. This will add more into the narrowing of the vascular lumen. If 90% or more of the vascular lumen is occluded by the newly formed thrombus and the fixed atherosclerotic plaque, then the patient usually presents with chest pain with minimal exertion or at rest, which we call unstable angina. However, if the thrombus results in complete occlusion of the vascular lumen, meaning 100% occlusion of one of the coronary arteries, then this will result in myocardial infarction. Patients with a stable angina usually present with a chest pain after certain level of exertion, due to the presence of fixed narrowing of more than 70% of the coronary artery lumen. This type of pain is relieved usually by rest or by drugs like the nitroglycerine. On the other hand, patients with unstable angina present with increasing pain after less level of exertion or sometimes at rest, and that's why it's called crescendo angina. This happens usually due to plaque disruption and thrombosis, distal embolization of the thrombus, and or vasospasm. Those patients usually have fixed narrowing of 90% or more of the coronary artery lumen. Transmittal angina or variant angina. This type occurs usually at rest, and it happens due to coronary artery spasm, either on an existing atherosclerotic plaque or on completely normal vessel. This type responds to vasodilators such as the nitroglycerine and the calcium channel blockers. Myocardial infarction or heart attack. In this type of ischemic heart disease, necrosis of the heart muscle is caused by ischemia. It affects around 1.5 million per year. One third die, and of those, half before reaching the hospital. Myocardial infarction happens after complete obstruction of the coronary artery lumen, means 100% occlusion. The most common scenario is caused by obstructive thrombus over a disturbed atheromatous plaque causing complete obstruction of the coronary artery, and this can cause massive myocardial infarction. Less commonly, in 10% of myocardial infarctions, infarction occurs in the absence of occlusive atherosclerosis and it's related to vasospasm. The subendocardial zone is the first part of the myocardium showing irreversible injury. And this is because the subendocardial zone of the myocardium is the last area to receive blood delivered by the epicardial vessels, which are present at the outer surface of the heart in one hand. On the other hand, it's exposed to the relatively high intramural pressure, which acts to decrease the blood flow to this layer. If the ischemic event continues, then more cells will die through the other regions of the myocardium, and the infarct reaches its full extent within 3 to 6 hours. In the absence of intervention, the infarct can involve the entire wall thickness, and this is what we call transmural infarction. This figure shows different macroscopic changes related to myocardial infarction. Please note that the posterior cardiac wall is at the top. The black arrow points to an area involved by acute myocardial infarction of the posterior lateral left ventricle. The arrowhead points to an old anterior scar, indicating a remote infarction. The star marks an area of myocardial hemorrhage due to ventricular rupture, and this was the acute cause of death in this patient. Let's start discussing the gross or macroscopic features of myocardial infarctions. Myocardial infarction of less than 12 hours old usually do not show gross changes. By 12 to 24 hours after infarction, red-blue discoloration appears. Then the infarct becomes softer, yellow-tan in color. By the 10th to the 14th days, infarcts are rimmed by a hyperemic granulation tissue. Weeks after, the infarcted tissue evolves into fibrous scar. Microscopically, the typical features of coagulative necrosis become detectable within 4 to 12 hours after the myocardial infarction. Necrotic myocardium induces an acute inflammatory reaction within 1 to 3 days. This is followed by the aggregation of macrophages. Macrophages come to the tissue to remove the necrotic myocytes and the neutrophil fragments, becoming more prominent within 5 to 10 days after myocardial infarction. Infarcted zone is progressively replaced by granulation tissue most prominent within 1 to 2 weeks after myocardial infarction. This figure shows the microscopic features of myocardial infarction. The first figure to the left is for a 1-day-old infarct, showing coagulative necrosis and wavy fibers if you compare that to the adjacent normal fibers to the right. The middle figure shows dense neutrophilic infiltrate in a 2 to 3-day-old infarct. The right figure shows almost complete removal of necrotic myocytes by phagocytic macrophages for a 7 to 10 days infarct. This figure shows also the microscopic features of myocardial infarction and its repair. Figure A is for a 1-day-old infarct showing coagulative necrosis and wavy fibers if compared to the adjacent normal fibers to the right. Figure B shows the dense neutrophilic infiltrate in a 2 to 3-day-old infarct. Figure C shows the almost complete removal of necrotic myocytes by phagocytic macrophages for a 7 to 10 days infarct. Figure D shows granulation tissue formation. Figure E shows a healed myocardial infarct consisting of dense collagenous scar. Clinically, patients with myocardial infarction presents with severe crushing chest pain that can be felt in the neck, shoulder, or even at the jaw. This type of pain is not relieved by nitroglycerin or rest. and it can be associated with sweating, nausea, dyspnea, shortness of breath, and sometimes vomiting. In 10 to 15% of cases, myocardial infarctions are silent, which means asymptomatic, particularly in elderly patients and diabetics. For patients suspected to have myocardial infarction, certain laboratory workup, including the creatinine kinase MB isoform and the troponins, is ordered. Troponins and the creatinine kinase MB isoform have high specificity and sensitivity for myocardial infarctions. The creatinine kinase MB isoform, or what's called the myocardial isoform, is more specific indicator for the heart damage. Its activity begins to rise within 2 to 4 hours after myocardial infarction, peaks at 24 to 48 hours, and return back to normal within 72 hours. So after 3 days, creatinine kinase MB isoform will be normal even if the patient had myocardial infarction. Troponins, on the other hand, including troponin I and troponin T, are detectable within 2 to 4 hours, peaking at 48 hours and remaining elevated for 7 to 10 days. This means that after 1 week of myocardial infarction, troponins will still be positive if you do a laboratory evaluation. Complications of myocardial infarction include contractile dysfunction. In most cases, there is some degree of left ventricular failure, manifested as hypotension, pulmonary congestion, and pulmonary edema. Arrhythmia is another complication because myocardial infarctions lead to myocardial irritability and conduction disturbances that can cause sudden death. Approximately 90% of patients develop some form of rhythm disturbance. Myocardial rupture, which complicates only 1 to 5% of myocardial infarctions. Chronic progressive heart failure due to the multiple myocardial infarctions. The outcome for patients with myocardial infarction: those patients suffer from 30% mortality in the first year and 3 to 4% mortality per year thereafter. For your questions, please email me at m.abdaljaleel@ju.edu.jo.